Infectious diseases, preventive medicine and clinical conferences concerning Species 3, 2024-2025, diseases of large ruminants, coronavirus enteritis in calves, bovine spongiform encephalopathy, chronic wasting disease of deer, infection with Schmallenberg virus, Crimean-Congo hemorrhagic fever, bovine coronaviruses, caused by the bovine coronavirus, BCOV, cause digestive and respiratory problems in domestic and wild cattle. They are widespread throughout the world, their incidence is very high in dairy and beef cattle farms, and the economic losses they cause can be considerable. If the role of the coronavirus is recognized in digestive infections, from calves to adults, the involvement of the virus as a major pathogen in the complex of respiratory diseases of young cattle is still subject to discussion, although its incidence has increased in breeding in recent years. The bovine coronavirus is a pneumoenteric virus that infects the respiratory tract, upper and lower, as well as the different segments of the intestinal tract of cattle. Bovine coronavirus and neonatal diarrhea in calves. Neonatal diarrhea, or neonatal gastroenteritis =GENN, constitutes the most important pathology of calves worldwide and is a source of considerable economic losses in cattle breeding. The most common causative agents implicated in this syndrome are Colobacillus, Cryptosporidia, bovine rotavirus, BROF, and bovine coronavirus, BCOV. Other agents can also be isolated during this pathology: bacteria, Salmonella, Clostridium, viruses, pestivirus, calicivirus, torovirus, and parasites, Giardia, Coccidia. The bovine coronavirus, involved in calf-GENN, has an antigenic community with viruses that can be found in respiratory infections due to BCOV or in winter hemorrhagic enteritis. If we specifically describe bovine coronavirus diarrhea, which affects young calves from 4 to 30 days old, more rarely before 4 days, after an incubation of 20 to 36 hours, diarrhea develops, over an average period of 4 to 5 days, with yellow to greenish feces, sometimes accompanied by fine clots of blood, or mucus, or curdled milk. The outcome can be fatal with dehydration, acidosis, heart failure or shock followed by death. The pathogenic power of the bovine coronavirus is mainly exerted in the ileum and colon. It is a malabsorption-maldigestion syndrome, with lesions on the small intestine and the colon. Coronaviruses abrade the intestinal villi, and the enterocytes are replaced by crypt cells, immature cells. The abrasion of the villi due to coronaviruses is much more significant than that due to rotaviruses. The symptoms observed are therefore more significant in the case of coronavirus disease. General signs can accompany diarrhea, such as depression and hypothermia. A survey carried out in suckling farms made it possible to observe the same proportion of calves affected by coronavirus diarrhea with or without depression, with or without fever. Also, noted the appearance and consistency of the feces, with a predominance of mucoid diarrhea, compared to liquid then pasty diarrhea. A formula count on blood samples can also highlight a reduction in the populations of lymphocytes and granulocytes. Pathogenicity of enteric viruses in calves, centralized table of identified intestinal viral pathogens. A thorough pathological examination will highlight the affected intestinal anatomical segment, as well as the presence of viruses in other organs. Histopathologically, the presence or absence of viral particles can be identified at the level of enterocytes, in the villi, and at the glandular level. The diagnosis of neonatal coronavirus diarrhea is made by analyzing feces in vivo or on dead animals. On feces samples, several methods can be considered: ELISA, hemagglutination on mouse erythrocytes, RT-PCR, reverse transcriptase polymerase chain reaction. These same authors had also isolated the virus in the nasal cavities by RT-PCR. Multivalent kits for neonatal diarrhea in calves have been developed in recent years, either based on the ELISA method or using an immune chromatography method. Possible samples depending on the viral agent suspected in calf diarrhea. Epidemiological: 3 potential profiles for neonatal coronavirus diarrhea are described: epidemic profile, All calves on the farm affected over a short period, epidemic puff, only part of calves affected over a short period, endemic profile, infectious episodes returning from one year to the next with a prevalence and severity that increase over the years. The prevalence of coronavirus calf diarrhea is considered by many authors to be higher in suckler farms than in dairy farms. The coronavirus alone was only found in 2% of samples, mainly on calves aged 2 to 7 days, far behind Cryptosporidia, 30%, and rotaviruses, 13%. These associations can intervene either simultaneously or successively. Excretion of the coronavirus, via the orofecal or aeronasal route, is high in the first 48 hours in sick calves. Can continue up to 14 days after infection and even last several weeks after recovery, in small quantities. This excretion is also possible in healthy calves, where no infection had been reported, but remains lower than that of sick animals, on average respectively from 0 to 8.2% versus 3 to 40%. In total, there could therefore be asymptomatic carriage possible in 5 to 30% of calves, after recovery or without clinical signs. Risk factors: neonatal coronaviruses are primarily linked to animals. Male calves are said to be more sensitive than young females. Newborn calves are twice as likely to be affected as older calves. The mother is a significant source of contamination for her calf. High seropositivity to bovine coronavirus among mothers of diarrheic calves, increasing with age and reaching an average of 94%. At the environmental level, we know the influence of the season. Neonatal diarrhea is autumn-winter conditions, extending from December to April, with a peak between January and March. Breeding management is also important. We observe more calf diarrhea problems during group calving. Poor transfer of immunity from the cow to its calf is also a major risk factor for neonatal diarrhea. Finally, poor overall hygiene of livestock breeding promotes contamination of calves. Bartels had blamed housing, crates, niches, not cleaned after the departure of the calves, or contact of healthy calves with congeners excreting coronavirus, calves having already experienced the disease. Megank added significant overall risk factors for GENN in 13 Flemish dairy farms: cleaning and disinfection of the calving box, rapid separation of the cow and calf after calving, the temperature of milk administration, bovine coronavirus and winter hemorrhagic enteritis. Winter hemorrhagic enteritis, WHE, winter dysentery equals WD, sometimes incorrectly called stomach flu, is a contagious, sporadic hemorrhagic enterocolitis, expressed in the form of epizootics in cattle farms during winter. Widespread throughout the world, affecting adult cattle, EHH is characterized by a high morbidity rate on farms, 50 to 100%, but a low mortality rate, less than 2%. The incubation period is 2 to 8 days, the acute phase of the disease lasts 3 to 6 days. Animals can usually recover within 2 to 3 weeks. The symptoms are characterized by sudden, profuse, foul-smelling diarrhea, with dark green to black feces and the presence of blood in 5 to 10% of cases. Diarrhea can also be accompanied by mucus. General signs can precede or accompany diarrhea, fever, apathy, anorexia, dehydration, if diarrhea persists, and sometimes cough and runny nose. This disease mainly affects dairy herds, particularly primiparous cows in the postpartum period, with high losses in milk production, from 15 to 95%. Depending on the severity of the symptoms and the recovery time, the economic consequences of the disease can last from a few weeks to a few months. In rarer cases, other categories of animals may be affected, adult cattle. In rarer cases, other categories of animals may be affected, cattle intended for fattening, adults and young people aged 6 to 9 months, calves and heifers of dairy breeds. In very rare cases, WHE has been diagnosed in adult cattle in the hot season. WHE must be distinguished from other infections, in particular from intestinal hemorrhagic syndrome in cattle, an emerging disease that appeared in the early 1990s and which the major causative agent is Clostridium perfringens type A. Toftaker developed an ELISA test to detect anti-BCoV antibodies from tank milk. The risk factors of the disease are linked to the animal, the breeding method and the environment, age of the cattle, especially young dairy cows after calving, history of infection to coronavirus, outside temperature, building confinement, ventilation, overall hygiene of the farm, effluent management, introduction of animals from outside, purchases, frequency of external visits to the farm. The means of fight mainly focus on two aspects: disinfection and air renewal. Rare vaccination trials, with vaccines prepared from viral strains of BCOV, isolated from cases of WHE, have been successfully carried out. However, Abuelo point out that after an episode of WHE, herd immunity develops which can last 3 to 5 years and thus prevent the breeding of a new infectious episode, which makes it less interesting the idea of implementing vaccination on the previously infected herd. Improperly called intestinal flu, the description of the disease practically summarizes the clinical signs and the lesional aspects, which appear in BCOV infection in calves, signs which can be confused with other respiratory diseases produced by other pathogens. It should be noted that while transport fever-BSE occurs at ages greater than 6 months, BCOV is more common in calves from the age of 2 weeks to 6 months. Immunity in bovine respiratory coronaviruses. The relationship between immunity induced by BCOV respiratory infections and protection is not clearly defined. The serum antibody titer against the bovine coronavirus could be a marker of the respiratory protection of calves and fattening cattle against the occurrence of a respiratory disease, via specific antibodies belonging to different isotopes, EG1, EG2, IgA. However, it can be difficult to distinguish whether these serum antibodies are correlated with protection, or whether they reflect previous natural, digestive or respiratory infection with bovine coronavirus. Despite a sometimes significant economic impact, no vaccine directed against respiratory coronaviruses has been developed to prevent pneumonia associated with BCOV in young calves, or in young cattle as part of the bovine respiratory complex. Only the benefit of intranasal vaccination of young cattle, at the entrance to the feedlots, using a live attenuated, commercial vaccine combining coronavirus, enteric calf strain, has been demonstrated in an American study. And rotavirus, in the reduction of antibiotic treatments prescribed for respiratory pathologies. The authors of this publication highlight the potential role of local immunity, via type A immunoglobulins. This concept of cross-immunity, between strains with different tropisms, enteric versus respiratory, is also the subject of debate in the scientific community. Diagnostic in bovine respiratory coronaviruses. Nasal excretion and the presence of respiratory coronavirus in the lungs of sick animals remains short-lived, in the absence of bacterial complications. This pathogenic agent will therefore be detectable during the acute clinical phase. The coronavirus has an RNA genome. The samples must therefore be stored at 4 degrees Celsius for a maximum of 24 hours and frozen beyond that, for rapid shipment to the laboratory, under cover of positive cold. There is very strong genetic homology between the respiratory and digestive coronavirus. The tests developed for the diagnosis of digestive coronaviruses can therefore be used for the detection of bovine respiratory coronavirus. Knowledge of the interactions between the respiratory coronavirus and various cofactors such as stress, bacterial superinfections and immunosuppressive viruses such as BVD must be improved. Another avenue lies in the study of reservoirs in wildlife, notably wild ruminants and birds, sources of coronavirus and potentially infections for farm animals. Bovine Spongiform encephalopathy-BSE in French, was first recognized in November 1986 in the United Kingdom. In retrospect, the first cases must in fact have appeared in the spring of 1985, but there is no definitive indication that the disease actually pre-existed in cattle, in this country or elsewhere. This disease can be compared to a set of other entities already known, in humans and animals, such as Creutzfeldt-Jakob disease and Kuru, man, scrapie, sheep and goats, chronic wasting, deer, and spongiform encephalopathy of farmed mink. These diseases are grouped under the generic name, subacute transmissible spongiform encephalopathies, TSE, and their agents are modestly called non-conventional transmissible agents, NCTA. We also talk about prion. BSE is listed as a disease in the Terrestrial Animal Health Code, published by the World Organization for Animal Health, OIE. This is a mandatory notifiable disease to the WA Terrestrial Animal Health Code. BSE is a disease for which the WA has established a list of countries and zones whose health status is officially recognized. Etiology. This prion corresponds to a protein, naturally present in the body, particularly in the brain. Its natural role is not yet completely understood. The disease is associated with a particular form of the prion, called resistant or pathogenic prion. Unlike the normal form, this new form of the protein accumulates locally. Understand how a protein without genetic material, without a trace of known nucleic acid, can be transmitted, and apparently reproduce, is the fundamental problem posed. The existence of different strains of pathogenic prions, well known in the case of sheep scrapie, further complicates the situation. The genetic sensitivity of individuals also plays a large role in the evolution of TSEs. The hypothesis of a purely genetic origin of these diseases is still a subject of discussion. Etiology. Epidemiology. Classic BSE versus atypical BSE. It is appropriate to distinguish these two forms, or strains. Classic BSE occurs through the consumption of contaminated food, see the transmission and spread section. While classic BSE represented a significant threat in the 1990s, the number of observed cases has declined significantly in recent years, following the application of effective control measures. Its level is currently estimated to be extremely low, number of cases close to zero. Atypical BSE refers to sporadic and natural forms of the disease. It appears to occur in all cattle populations at a very low frequency and has only been identified in older cattle following intensive surveillance. In the early 2000s, atypical prions causing atypical BSE were identified following increased surveillance of transmissible spongiform encephalopathies. The number of cases of atypical BSE is negligible. Indeed, if to date there is no evidence that atypical BSE is transmissible, the recycling of the atypical BSE agent is not excluded, and therefore, exposure risk management measures in the food chain continue to be recommended, as a preventative measure. For more details, see BSE Global Situation and Annual Incidence Rate. BSE is a WO-listed disease and must be notified to WO, as mentioned in its Terrestrial Animal Health Code. Atypical BSE is excluded from the procedure for official recognition of health status in terms of BSE risk, given that it can occur spontaneously in all cattle populations. Symptoms and risk factors. Clinically, the disease appears in cattle over 2 years of age. Cases in slightly younger individuals are rare. Conversely, animals aged 9 or 10 can still develop BSE. This is to be associated with the recognized long incubation of the disease of around 2 to 5 years. The first clinical signs are subtle and mainly concern changes in behavior, difficult to spot for anyone other than the breeder, who is used to seeing the animals in his herd every day. These signs can begin with a drop in production with a preserved appetite, continue with a more difficult attitude in the milking parlor, kicking, apprehension, hypersensitivity to external stimulations, isolation of the affected animal, of rest of the herd. The evolution can last from a week to a year, with stable phases and progressive phases. Hypersensitivity may only be temporary. At the end, the animal presents real locomotion and balance problems, which go as far as the impossibility of getting up. At the physiological level, bradycardia, decrease in heart rate, is regularly observed, whereas we would rather expect tachycardia, at least during the hypersensitivity phase. The origin of the disease is still debated, but it is suspected that meat and bone meals, MBF, distributed to cattle, mainly dairy cattle, are used in addition to their usual diet. The starting point would be a change in the methods of fat-protein separation in these FEOs, with a modification of the cooking temperatures, and the support for lipid extraction, organic solvent at dry temperature, replaced by moist heat. A bovine origin or a sheep origin, tremblant, of the agent remains to be determined. The fact that the prion strain responsible for BSE is not known in sheep speaks in favor of a bovine origin, but the absence of any isolation prior to 1986 in cattle does not allow us to decide. We also suspect a possible vertical transmission, from mother to young, of BSE. Secondary cases have been recorded in antelopes, wild bovids, and wild felids in zoos, as well as in domestic cats, mainly in the United Kingdom. Clinical signs. Conclusions. Since the time lag between contamination of an animal with a BSE agent and the appearance of clinical signs is 2 to 8 years, clinical signs of BSE are only observed in adult animals and may be the following: nervous or aggressive behavior, depression, hypersensitivity to noise and touch, muscle twitching, tremors, posture abnormalities, coordination problems and difficulty getting up, weight loss, decreased milk production. The disease usually progresses from subacute to chronic, and affected animals gradually exhibit neurological symptoms. There is no effective treatment, and the outcome is death of infected animals. Public health risks linked to BSE. Some data indicate that the new variant of Creutzfeldt-Jakob disease in humans could be attributable to the consumption of contaminated beef, by infected nervous tissues, or to the use of medical devices made from animal tissues. Infected. The obligatory systematic removal of all nervous and lymphatic tissues visible on bovine carcasses, misses specified risk materials, as well as the elimination of any suspect animal from the human food chain makes it possible to eliminate the risk linked to consumption. Suitable procedures for handling nervous and lymphatic tissues from suspect animals in slaughterhouses and laboratories are indicated to avoid any accidental human exposure, ocular or oral nasal. Milk and dairy products are considered safe. The manufacturing of pharmaceutical products for human or veterinary use, medical devices and cosmetics must respect rigorous constraints. Forecast: by 1999 the disease was clearly in decline in the UK. However, the decline was slower than expected. Two questions arise. 1. Could the slowdown in decline be due to transmission phenomena other than food and maternal routes, contamination during birth? It must be remembered that, at this stage, the route maternal remains a hypothesis, but it could explain a certain percentage of the cases observed. The great initial importance of the food route could have hidden other possibilities of contamination. 2. Will the epizootic completely stop in a few years, or will sporadic cases be able to occur? Continue to appear? On the other hand, the evolution of bovine disease in the various affected countries has made it possible to highlight certain difficulties in completely mastering the slaughterhouse, rendering and feeding livestock. On the other hand, we may not know all the possible sources of prion. This disease has really had serious consequences for the cattle industry. A question like the traceability of products was able to advance quickly in this context, from farms to distribution circuits and places of sale. Marketing. The impact of BSE on the beef industry required rapid and reliable responses to consumer questions. Fight against BSE. Until 2000, the bovine Spongiform encephalopathy-BSE surveillance program was based on the Network National Epidemiological Clinical Surveillance, which provides for a post-mortem laboratory examination on suspected animals showing clinical signs of the disease. Animals imported from countries having declared cases of BSE. Animals slaughtered urgently, and whose reference analytical methods, at national and international level, used are histopathological examination of nervous tissue, the Western blot. This national clinical epidemiological surveillance network has been strengthened, June 2000, by a screening testing program on a target population using rapid immunological tests, January 2001, by systematic screening of cattle over 30 months of age entering the food chain. Furthermore, the regulatory requirements relating to BSE evolved during the year 2000. Diagnosis. BSE can be suspected based on clinical signs. To date, there is no method to confirm the presence of the BSE agent in live animals. The WO Manual of Diagnostic Tests and Vaccines for Terrestrial Animals states that diagnosis can be made by histopathological examination, microscopic examination, of the medulla oblongata, part of the brain. However, Histopathology as a primary diagnostic method is not sufficient for the different types of surveillance indicated in the terrestrial code. The diagnosis is confirmed by the use of immunochemical tests including immunohistochemistry, IHC, techniques and the Western blot test. The Epidemia Surveillance Network. Created in 1990, this national clinical epidemia surveillance network involves breeders, veterinarians, laboratories, veterinary services, and is based on the surveillance of herds on farms or at the slaughterhouse. It aims to identify any cattle presenting neurological disorders. The cattle is then considered suspect. Ensure the collection and analysis of suspected cattle brain, in order to diagnose cases of BSE and be able to intervene as quickly as possible. BSE Research and Surveillance Program. Reminder of the objectives and terms of the research program. The research program was launched following the opinion delivered by the Dormont Committee in March 2000 and anticipated the European decision of June 2000 asking the countries of the European Union to carry out a screening test program in 2001. A dual objective to strengthen the protection of public health. Estimate the prevalence of the disease, i.e., the number of BSE cases in a specific population, that of cattle at risk in the incubation phase of the disease, in order to improve epidemiological knowledge of BSE on the national territory. Compare rapid tests with the official conventional methods used until now, Western blot and histological examination of the brain, which are poorly suited to for large-scale use. The targeted population, so-called at-risk cattle. The research program focuses on cattle aged over 24 months, identified as a population potentially at risk, namely cattle that died of natural death, sick cattle, cattle slaughtered urgently due to an accident. This target population is the same as that proposed by the European Commission as part of the Programme for Rapid Post-Mortem BSE Detection Tests in all member states of the European Union, a program implemented from January 2001. The test chosen, the Prionics test. This test was chosen by the government on the proposal of a commission from among the 3 tests validated by the European Commission. 3 major reasons led to the choice of this test. Sensitivity and reliability. Training, assistance and after-sales service. Adaptation to the constraints of the terrain for the realization and simplicity of the transfer of samples. European scientific experts recently managed to agree on the ranking of countries with regard to the risks of dissemination of BSE in their cattle herds. 4 categories. 1 high risk, United Kingdom and Portugal. 2 low risk, corresponds to countries in which the disease is confirmed, but at a low level. France, Denmark, Ireland, the Netherlands, Switzerland, Belgium, Luxembourg, Spain, Germany, and Italy. 3 unlikely but not totally excluded risk, Finland, Austria, Sweden, Canada and the United States. 4 highly improbable risk, Argentina, Australia, New Zealand, Chile, Norway, and Paraguay. In any case and whatever the level of risk, all member states are subject to the community regime for the withdrawal of risky materials which was adopted by the Council of Ministers of Agriculture, Prevention and Control Measures. Any effective strategy to prevent the introduction of BSE or combat observed cases must include targeted surveillance of cases of clinical neurological disease, transparency of declarations relating to cases of BSE discovered, routine tests at slaughterhouses, precautions relating to imports of live ruminants or ruminant products, in accordance with the WA Terrestrial Code, elimination of specified risk materials, brain, spinal cord, at the slaughterhouse during carcass processing. Prohibition on the inclusion of specified risk materials in animal feed in order to eliminate potentially contaminated materials from the food chain. Slaughter, in humane conditions, of all suspect and susceptible animals exposed to contaminated food, WA Terrestrial Animal Health Code. Proper destruction of dead animals and all products of animal origin, WA Terrestrial Animal Health Code. Identification of livestock allowing effective surveillance and monitoring of suspected cases. Chronic wasting disease. It is a degenerative and fatal disease that affects the brain of deer. It is caused by an abnormal prion, a tiny protein, which is transmissible from an animal to another and which can accumulate in the environment if emitted by infected animals. Affected animals may carry the disease for years before showing symptoms. There is no treatment or vaccine against this disease. Chronic wasting disease, CWD, of deer, has been, since April 4, 2001, a notifiable disease which is subject to the authorities under the Regulation on the Health of Deer Animals. Since 2000, and particularly since the beginning of 2001, the diagnosis of CWD has been confirmed in several farmed swappities on different farms. It is invariably fatal. It belongs to a group of diseases known as transmissible spongiform encephalopathies, TSEs, which includes diseases such as scrapie, bovine spongiform encephalopathy-BSE, and Creutzfeldt-Jakob disease, CJD, in humans. Species that can contract CWD, the majority of deer family, are susceptible to contracting CWD. Vulnerable species include white-tailed deer, mule deer, elk, moose and caribou. In Canada and the United States, cases of CWD have been reported in white-tailed deer, mule deer, elk and moose. In Norway, reindeer are also affected. No cases of CWD have been detected in North American caribou populations. Clinical signs CWD is difficult to be confirmed. Screening for the disease while the animal is alive is currently impossible. Additionally, it can take up to 36 months after the start of the infection before the animal shows clinical signs. Thus, once introduced into a population, this disease risks being extremely difficult to control. Clinically affected animals are usually 3 to 4 years old. They may demonstrate clinical signs for weeks and even months before succumbing to the disease. Clinical signs observed generally include unusual behavior, incoordination and progressive loss of body condition. Any of the following signs, shown by a deer over 16 months old, may mean that it has CWD: abnormal aggressive behavior, signs of panic, inability to accurately judge distances and space, depression or lack of interest in the animals around them, without other signs of illness, thirst or excessive urination, difficulty swallowing, possibility of foreign body pneumonia leading to death despite treatment with antibiotics, gradual weight loss and deterioration in health. Transmission mode. The exact cause and mode of transmission of CWD are unknown, but it is believed to be caused by a new category of protein-based infectious agent called prion. It is also believed that the disease can be transmitted from mother to fetus, or between animals in the same herd through bodily secretions, and/or through contamination of food or water, through saliva, feces or urine. There is no evidence that the disease can be transmitted naturally to animal species other than deer and elk. Currently, there is no treatment or vaccine for this disease. The risk to human health. According to experts and public health authorities, there is currently no evidence that CWD in deer can be transmitted to humans. However, it took some time to make the connection between the consumption of meat from cattle affected by mad cow disease and variant Creutzfeldt-Jakob disease in humans. The risk of crossing the interspecies barrier exists, and several years may pass before confirmation of transmission of CWD to another species, or to humans, is obtained. We must absolutely ensure that potential exposure to this group of diseases is reduced, legitimately invoking the precautionary principle, even if the scientific evidence is not yet available. The WHO has also advised all countries where cases of CWD have been reported to put in place surveillance and control measures against this disease. Schmallenberg virus is a virus of the Bunyaviridae family, identified since November 2011 in several samples from cattle and sheep, presenting atypical symptoms. In Europe, epidemiological surveillance of cases of atypical diseases in cattle, sheep and goats has been implemented, and breeders have been encouraged to report each suspicion to the competent authority. The disease is not among the diseases requiring notification to the WA, but must be notified as an emerging disease. Orthobunya affecting cattle are widely distributed in Oceania, Australia, and Africa, and they initially cause mild clinical symptoms. If pregnant females become infected, congenital damage, premature births, and reproductive disorders can occur. Viruses are usually transmitted by insect bites. These viruses, which have a preference for cattle, do not represent a threat to humans and are not zoonotic. The relationship between Schmallenberg virus and Shamanda, Ino and Akabane viruses does not suggest a risk to humans. Etiology. Classification. Viruses of the Bunyaviridae family are classified into 5 genera: orthobunyavirus, hantavirus, nairovirus, flibovirus, and tospovirus. The Bunyaviridae are enveloped single-stranded RNA viruses of negative polarity and whose genome is composed of 3 segments: small, medium, and large. The S segment encodes the nucleocapsid and non-structural proteins. The M segment encodes the surface proteins GN and GC glycoproteins, and the L segment encodes the viral polymerase. See figure. Surface proteins responsible for attachment, cell fusion, and hemagglutination. These proteins are likely to contain important virulence factors. Neutralizing antibodies are directed against epitopes on G1 surface glycoproteins. Other viruses of medical importance belonging to the Bunyaviridae family, such as the Ropuche virus, genus Orthobunyavirus, and the virus responsible for Crimean-Congo hemorrhagic fever, genus Nairovirus. At least 30 orthobunyaviruses have been associated with human illness, causing severe febrile syndrome. Epidemiology. Transmission. Orthobunyaviruses are generally transmitted by mosquitoes, Calicoidae, or midges, Calicides, and the life cycle of these viruses involves a limited number of blood meals, from vertebrates, in which they can replicate, and can eventually subsequently spread through the migration of infected animals. Infection of hosts is generally inapparent, however infected animals develop sufficient viremia, allowing mosquitoes and midges and other biting insects to become infected. Man is considered a dead-end host. Reservoirs. Orthobunyaviruses are found in a wide varieties of reservoirs, including wildlife, sloths, marmosets, and in domestic animals, cattle, pigs, goats. Worldwide distribution. Viruses of the Orthobunyavirus genus are widely present in Oceania, Africa, Asia, Australia, and have been reported in Israel. These viruses affect cattle, buffalo, sheep, goats, horses, and dogs and cause mild, generally unremarkable symptoms. Epidemiological situation in Europe. Between August and October 2011, cases of acute infection with Schmallenberg virus were reported in cattle in Germany and the Netherlands. In addition, since December 2011, cases of malformations linked to this virus have been reported in sheep and goats. In Germany, 14 sheep farms affected on January 10, 2012. In Belgium, 14 sheep farms affected on January 6, 2012. January 2012, and in the Netherlands, 52 outbreaks confirmed as of January 9, 2012, 51 sheep farms and 1 goat farm. Following image. Clinical manifestations. The clinical signs reported are based on the observations of veterinary practitioners, who have reported cases of disease in cattle and sheep. In several herds, some animals showed a fever exceeding 40 degrees Celsius, and poor general condition, loss of appetite and drop in milk production, sometimes diarrhea and abortions. The symptoms disappear after a few days. In sheep, the most important sign that reveals an unusual condition is the abnormal rate of stillbirths or abortions, and birth defects. Photos. Transmission is permitted by calicoids, hence a seasonal epidemiology. Treatment is purely symptomatic, with no vaccine or specific treatment available. There is currently no indication of risk to human health. Measures taken by infected European countries. The veterinary services of European countries have implemented surveillance of this pathology based on clinical surveillance of malformations in ruminants aimed at detecting the circulation of the Schmallenberg virus. The EU has implemented reinforced surveillance measures in the most at risk of introducing the virus, namely the border regions with Belgium and Germany. The case definition according to veterinary services. Suspicious clinical case is defined as the appearance in cattle and/or sheep and/or goats. Abortion or malformed newborn. Newborn with neurological disorders. Crimean-Congo hemorrhagic fever, CCHF, is a zoonosis transmitted by ticks which is distributed over more than 30 countries in Europe, Asia, and Africa. The causative agent is the Crimean-Congo hemorrhagic fever virus, CCVF, of the genus Nairovirus, family Bunyaviridae, which is characterized by large genetic variability. Humans become contaminated by tick bite or by contact with biological fluids, animals or infected subjects. The clinical picture is marked by unspecific initial symptoms, then progression towards a hemorrhagic phase which can jeopardize the vital prognosis in 10 to 50% of cases. The biological signs classically show thrombocytopenia, an elevation of hepatic or muscular cytolysis enzymes and cholestasis, as well as coagulation disorders. The definitive diagnosis is based on viral isolation, genome detection by molecular techniques, RT-PCR, or detection of anti-VFHCC antibodies by serology. There is no specific treatment for the disease, and to date, the effectiveness of ribavirin remains controversial. In the absence of a vaccine, prophylaxis is essentially based on vector control, protection and information of populations and healthcare workers. Etiology. VFHCC belongs to the genus Nairovirus, of the Bunyaviridae family. This viral family also includes orthobunyavirus, hantavirus, phlebovirus, and tospovirus. The Nairovirus genus is grouped into 34 viruses transmitted by ticks. They are classified into 7 serogroups, the most important of which are the group FHCC, which includes VFHCC and Hazara virus, as well as the group Nairobi sheep disease, NSD, to which the NSD virus and the DUB virus belong. VFHCC and NSD virus are the only known nairoviruses pathogenic to humans. FHCC virions are enveloped, spherical particles with a diameter of 80 to 120 nanometers. The virus genome is made up of 3 single-stranded RNA strands of negative polarity, organized in the form of 3 ribonucleoproteins, RNPs, with a helical structure and circular appearance, due to the complementarity of the 5 and 3 ends. These 3 segments L, large, M, medium, and S, short, respectively encode the RNA-dependent RNA polymerase, the 2 enveloped glycoproteins, GN and GC, and the nucleoprotein. Analysis of VFHCC genomic sequences showed that the different viral strains isolated in various regions of the world and during several epidemics presented great variability, and could be grouped into 7 different clades. The analysis showed a predominance of genotypes 3-5-7 in Africa, genotypes 1-2 in Asia and the Middle East, while in Europe genotypes 4-6. Etiology. The existence of discrete clades. These clades could be classified according to extensive geographical areas, distant and different from each other. These geographical areas indeed differ from each other by their climate or even their vegetation. All of these differences have thus influenced the fauna present in this location, and led to the evolution of different species of ticks and vertebrates, and therefore the need for VFHCC to adapt to the specific hosts of the given region. These geographic differences have therefore led to the emergence of viral variants at the local level. It is important to take into consideration these different viral adaptive capacities in certain geographic areas, as this could potentially lead to differences in the virulence and pathogenicity of the virus. Long-distance virus transfer. According to the geographical distribution and the existence of different clades, we can highlight that several clades can contain virus strains from regions distant from each other. Thus, despite the topographical and geographical separations, the presence of viruses with linked sequences seems to indicate that different geographical areas could have been linked by a mechanism of long-distance transfer of infected ticks, allowing a strain of VFHCC to adapt to a new environment and to stay in it. A vertebrate host can then risk being bitten and infected by a tick carrying a local virus strain, but also by a tick carrying a newly introduced virus strain. This could then increase, during the co-feeding mechanism, the probability of recombination and genetic reassortment of VFHCC, and thus continue to make it evolve. Long-range transfer of VFHCC can occur via different mechanisms. Transport of infected immature ticks via migratory birds. International livestock trade, which results in the movement of livestock that may be infected. It thus increases the risk of introducing the disease but also of ticks potentially attached to the infected animal, in geographical areas previously considered naive for the disease or for a strain of the virus. These two mechanisms nevertheless differ from a temporal point of view. The first can be described as ancestral, because it has possibly taken place for thousands of years, while the second is relatively recent, and increases day by day with globalization. This last mode of transfer reflects the dynamic character of genomic variability of the virus. The causal agent, the analysis showed a predominance of genotypes 3-5-7 in Africa, genotypes 1-2 in Asia and the Middle East, while in Europe genotypes 4-6 mainly circulate. The first recognized and documented cases of Crimean-Congo hemorrhagic fever date back to during the Second World War, in 1944 in Crimea, former USSR. In the following decades, the disease was mainly observed in regions of Eastern Europe, but also in Africa. Nevertheless, since the beginning of the 2000s, the incidences of the pathology and the presence of the tick have considerably increased. These vectors are now found in many regions of the globe, ranging from Western China to the Middle Orient, but also in a large part of the African continent. This represents a wide distribution, particularly in Algeria, Armenia, Azerbaijan, Egypt, Ethiopia, Georgia, Iran, Iraq, Israel, Morocco, Sudan, Syria, Tunisia and even Turkey. They are also present in a large part of Eastern Europe, Albania, Bosnia-Herzegovina, Bulgaria, Croatia, Cyprus, Kosovo, Macedonia, Moldova, Montenegro, Romania, Russia, Ukraine, and in recent years, they have been found also in Western Europe, notably in Italy, France, Greece, Portugal and Spain. Figure: Epidemiology. Geographic distribution. CCHF is a viral disease transmitted by ticks, the area of which of geographical extension is the largest without being exclusively tropical. The circulation of the virus currently overlaps with that of ticks of the Hyalomma genus. There is still potential for expansion because neither FHCC nor VFHCC have been detected, to date, in America and Australia. CCHF occurs in an endemic mode in steppe, savanna and semi-desert biotopes in more than 30 countries in Africa, southeastern Europe, the Middle East and Asia, figure before. There is a seasonal summer recrudescence, sporadic cases closely linked to epizootic episodes, in amplifier hosts, wild and domestic mammals. CCHF can also manifest in an epidemic mode, which results from an essentially nosocomial spread also found in Western Europe, notably in Italy, France, Greece, Portugal and Spain. Figure: VFHCC circulation cycle, vector and reservoir. VFHCC has been detected in several species of ticks belonging to the families Ixoididae, hard ticks, or Argacidae, soft ticks. However, ticks of the Hyalomma genus, Ixoididae family, constitute the main long-term reservoir of the virus and the vector of the disease. The occurrence of FHCC in Europe, Asia, and Africa coincides with the global geographic distribution of Hyalomma ticks. The virus can persist throughout the life of the tick and is transmitted transstadially. There is also vertical and sexual transmission, demonstrated experimentally in the Hyalomma truncatum tick. Naive ticks could become infected by carrying out a blood meal on a host refractory to VFHCC on which infected ticks were feeding. VFHCC circulates in nature according to an enzootic tick vertebrate cycle, figure followed. Large wild and domestic vertebrates, on which ticks gorge on blood, contribute to the amplification of the virus and represent the main hosts of adult ticks. Seroepidemiological surveys carried out in endemic areas have demonstrated a high prevalence of anti-VFHCC antibodies in livestock such as horses, donkeys, goats, sheep, cattle, sheep and pigs, as well as in large wild herbivores, giraffes, rhinoceroses, buffalo. Furthermore, VFHCC has been isolated from numerous small wild mammals, hedgehogs, hares, rodents, genets, favored targets of immature ticks, larvae and nymphs. Although many animal species can be infected, VFHCC is only pathogenic in humans, newborn mice, and a lethal genetically modified mouse model. Most birds appear refractory to infection but could nevertheless play a role in the dissemination of VFHCC, particularly migratory birds when infested by infected immature ticks. Ostriches are the only avian species known to be susceptible to infection, and several cases of human contamination have been reported during 2 epidemics that occurred on farms in South Africa. Clinical and biological characteristics of the infection. Short incubation, between 1 to 3 days after tick bite, and 5 to 6 days after contact with blood or other biological fluid. Pre-hemorrhagic phase, with sudden onset associating, between the 2nd and 4th day. Flu-like syndrome, fever, chills, headache and arthromyalgia. Digestive disorders, nausea, vomiting, diarrhea, diffuse abdominal pain. Mood disorders, confusion, aggression then depression and insomnia. Asthenia and drowsiness. Cardiovascular disorders, tachycardia, hypertension. Lymphadenopathy, hepatomegaly. Hyperemia on the head, chest, conjunctiva. Hemorrhagic phase, between the 3 and the 6th day. Subcutaneous hemorrhages, petechiae, bruising of the mucous membranes and the skin. External hemorrhages, epistaxis, hemoptysis, hematemesis, melena, hematuria, menometrorrhagia. Internal hemorrhages, pulmonary, retroperitoneal, intracranial. Multivisceral failure, hepatorenal insufficiency, cardiopulmonary insufficiency. Between the 5 and the 14 day. Convalescence persistent asthenia, tachycardia, labile pulse, alopecia, polyneuritis, xerostomia, amnesia, decreased visual acuity, deafness. Clinical and biological characteristics of the infection, leukopenia, thrombocytopenia, decrease in hemoglobin, coagulation disorders. Diagnosis. CCVF infected samples can only be handled in a maximum security level 4, P4, laboratory. Certain diagnosis is usually carried out using samples of blood, plasma, serum, or other biological fluids, saliva, urine, etc., and biopsies. It is based on I. Direct search for the pathogen, isolation of the virus, detection of the viral genome by RT-PCR, as well as viral antigens. 2. Immunological tests allowing the detection of IM and IG anti-VFHCC antibodies, certainty diagnosis. Detection of VFHCC and viral antigens can be done via several methods: cell culture, RT-PCR or real-time PCR, or the ELISA method, but which is less sensitive. It is only used for diagnosis of the acute stage of CCHF, if the laboratories are not equipped with an RT-PCR test. Cell culture allows detection of viremia, which is elevated from the onset of the disease. From blood samples taken in the first 5 days of the disease, VFHCC can be isolated by infecting different cell lines, VRO6, VHK21, SW13, LLC-MK2. This technique is simple, precise, but slow, 2 to 5 days, and not very sensitive, because the virus produces little if any cytopathic effect. Viral identification then requires an immunofluorescence technique coupled with specific monoclonal Abs. This method is therefore not suitable for rapid diagnosis, especially since it requires access to a BSN-4. Molecular biology, the method of choice used is RT-PCR. This technique is very specific, very sensitive, and allows rapid diagnosis of VFHCC infection. It is often used as a first-line tool in the diagnosis of CCHF. This test will therefore make it possible to detect viral genetic material, without the need to cultivate the virus. We can thus detect the virus until the 16th day of illness. This method also contributes to molecular epidemiology. It is possible to sequence the amplified viral complementary DNA and submit it to phylogenetic analysis. In addition, real-time PCR tests are now used, which are much more practical because the risk of contamination is reduced. They also have increased sensitivity and specificity, are faster, and make it possible to quantify the viral load. Detection of anti-FHCC antibodies occurs at a more developed stage of the disease, by studying the presence of IgM and IgG directed against the viral nucleoprotein. This presence of antibodies is mainly observed in patients who survive the disease. In order to detect a recent infection, it is necessary to detect the presence of specific IgM, the presence of seroconversion, a massive increase, more than 4 times, in the presence of specific antibodies between 2 blood samples in a row. Indirect immunofluorescence, IFA, this technique will allow the detection of IgM and IgG approximately 7 days after the start of symptoms. IgM are the early markers of the disease, with a maximum level around the start of the 3rd week, and disappearance during the 4th month. IgG remains detectable for 5 years. However, this technique remains less sensitive than the ELISA method. ELISA method is the most used technique because it is more specific, more sensitive, easier to use, and inexpensive. It also allows the detection of IgG and IgM, which bind to the specific antigens used. It is used in particular to carry out epidemiological surveys. More recently, new techniques have been developed. One of them notably uses recombinant VFHCC nucleoproteins as antigen in ELISA tests to detect virus-specific IgM and IgG. Another technique consists of the use of the double antigen sandwich ELISA method to allow independent detection of the VFHCC-specific AB species. Prophylaxis. Prophylaxis is therefore based on simple measures against the transmission of the disease within health structures, but also more generally among populations living in endemic areas. Prevention of nosocomial risk consists of: isolate sick patients, wear protective clothing for healthcare personnel, respect universal hygiene precautions, single-use materials, treatment and specific circuit of excreta and medical waste. Train medical staff on the risk of infection by VFHCC. In addition, for populations staying in VFHCC circulation regions, risk prevention combines 2 types of individual and collective actions. Environmental measures for vector control, deworming with pyrethrin-type acaricides, and avoidance of tick bites, limiting contact with vegetation, wearing clothing covering uncovered areas, using skin repellents, removing ticks as quickly as possible, carefully using special hooks. Information measures to encourage individuals to consult at the slightest sign suggestive of FHCC. All of these strategies are part of a more general framework for controlling viral diseases, prevention and individual protection in populations at risk. Alongside the various strategies to combat the parasite, health and personal protection measures will allow individuals to reduce the risk of contamination as much as possible. The CCHF virus is transmitted to humans through contact with blood, bodily fluids or tissues of infected animals, or through the bites of infected ticks, particularly among people living in endemic areas where ticks may be present. Hyaloma. It is in slaughterhouses that transmission between infected animals and professionals is at greatest risk. Workers are in direct contact with blood or tissue from animals which can be infected, and therefore also contract the virus. Other professionals may also be at risk, farmers or veterinarians, both of whom may be exposed to blood, but also directly to ticks that may be present on animals. The most risky situations are butchering, contact during birth, veterinary interventions, or even the elimination of carcasses or fetuses. This is why we must insist on the use of suitable clothing, in order to limit the risks associated with this exposure as much as possible. It is also possible to quarantine the animals, or to subject them to chemical treatment with antiparasitic agents 2 weeks before entering the slaughterhouse.